I'm giving this talk on behalf of all of my colleagues who worked on this project with me, and you can see them listed here as well. I would like to also acknowledge the Pharmacogenetics Research Network that paid for some of the clinical data, the Metabolomics Network led by Rima Kador-Duke I'm going to present some data from that, and then of course the UF Southeast Center for Integrated Metabolomics and Sanford Burnham, who ran the data for us. So with that, we'll go ahead and just so that everybody knows, the only disclosures I have are related to the funding for this project. As well, I received a small travel stipend to come and present these data to you. So by way of background, let me begin with just a few words on beta blockers. So beta blockers are a very commonly prescribed antihypertensive class of drugs. They're very effective for blood pressure lowering and cardiovascular event reduction. That's why we treat blood pressure is to prevent things like myocardial infarction, stroke, and death. But the downside is beta blockers are also associated with increases in glucose to the point where you could actually see impaired fasting glucose, which we all know is a diabetes intermediary phenotype, as well as frank diabetes. And we have published previously that beta blockers are associated with an increased risk for impaired fasting glucose in those subjects who have abdominal obesity, which we also know is a risk phenotype for diabetes. So the mechanisms that are associated with this dysglycemia are not very well understood. And they are very variable. You can't look at a patient and say, okay, you're going to have dysglycemia after we treat you with this drug, and you're not. We can make guesses based on what they look like, what they kind of feel like, but there's no way to clearly delineate this risk. So we believe identifying biomarkers that could predict this new onset dysglycemia would be helpful and would be a way for us to begin to personalize a safer treatment approach to hypertension management. So there has previously been in the last few years a paper published from the Framingham study, and there are many papers like this. I'm just pointing to this one as a background, where a cluster of branched chain and aromatic amino acids were highly associated with incident diabetes. And this work has been replicated actually in many different phenotypes and many different studies. And so we asked the question in our clinical data set, do those same 5 aromatic and branched chain amino acids associate with impaired fasting glucose? And sure enough, as you can see here, we looked at isoleucine, leucine, valine, tyrosine, and phenylalanine, and you can see that individually, they were all associated with new onset impaired fasting glucose after just 6 to 9 weeks of treatment with this drug. And when we looked at a composite p-value, composite p for all 5 of the amino acids, you can see it was highly statistically significant. And we published this work last year in Cardiovascular Genetics. We also looked at the genes associated with catabolism of these branched and the aromatic amino acids, and you can see for BCAT1 as well as for PAH, we saw a statistically significant trend for, my slides just disappeared, increasing risk based on genotype for impaired fasting glucose. So all of that is just by way to lead us to the rationale for the current pilot and feasibility study. We asked the question, what else might be affecting one's risk for this phenotype? And so we thought about the fatty acids and fatty acid oxidation, which we know vary based on insulin resistance status and obesity status. We know that lipid overload leads to increased fatty oxidation in skeletal muscle, and this also coincides with accumulating acylcarnitines. And so acylcarnitines have also been implicated in insulin resistance and diabetes, the short chain, the long chain, and the branched chain amino acid derived acylcarnitines. So that led us to ask the question in our pilot and feasibility study, does variability in acylcarnitine metabolite signature contribute to the inter-individual variability for risk for glucose change after treatment with atenolol? And again, we worked with the UF core as well as Sanford Burnham on this project. So let me give you just a couple of background slides on the clinical trial that we used. And again, this is funded by the Pharmacogenomics Research Network. The study is called the Pharmacogenomic Evaluation of Antihypertensive Responses, or PAIR. This was a prospective randomized clinical trial where we evaluated blood pressure response as well as adverse metabolic effects of the drugs that we treated the patients with. We enrolled patients who were between 17 and 65 years of age, all of whom had uncomplicated hypertension and really no other diseases. They were excluded if they had diabetes or heart disease or other things like that. We enrolled patients from the University of Florida in Gainesville, as well as the Mayo Clinic in Rochester and Emory University in Atlanta. So based on those three sites, you can imagine we had a rich racial mixture. The UF and Mayo Clinic enrolled Caucasians, and the UF and Emory universities enrolled African Americans. The data I'm going to show you today are limited to our Caucasians. And lastly, with regard to treatment, patients were randomized to get treated first either with hydrochlorothiazide, which is a thiazide diuretic, or atenolol, which is the subject of the paper that I'm presenting to you currently. And this just shows you what the treatments looked like. Everybody started out with a washout to make sure we were at a good baseline. We then did a baseline assessment where we obtained blood pressure values as well as plasma, serum, DNA, et cetera. So those served as the baseline. Then we used either hydrochlorothiazide or atenolol monotherapy, so that was the only drug they were exposed to for 6 to 9 weeks. And then we did response assessments at that time point, which includes labs. And so that's the time point that I'm going to present to you today. And at that assessment response visit, we did, again, plasma, serum, biomarkers. And so all of our samples were obtained in the fasting state in the morning, and they were done universally across all sites with the same tube collection, the same processes. With regard to the glucose measurement, fasting glucose, again, after 6 to 9 weeks of treatment, we used standard systems to analyze our glucose. They were all done at the Mayo Clinic, which served as our core lab. And the glucose change is the level after atenolol exposure minus that before atenolol exposure. So pretty clear there. The acylcarnitine quantitation was done again at Sanford Burnham. We used baseline levels of acylcarnitines for this project. The assay was designed to measure 57 different acylcarnitines. We used serum as our analyte of interest, and they used an LC-MS system. The ACs that were below the limit of quantitation, and each one had its own level, were designated as 0. 29 unique acylcarnitines were able to be quantified in greater than 20% of the serum samples, and those are the ones that are included in the presentation that is going to follow. With regard to statistical analysis, we really used two different approaches. the first approach for the 21 acylcarnitines that we were able to quantify in more than 80% of the samples, we did linear regression between the AC level and the glucose change. We used unadjusted and adjusted analyses, adjustments for baseline glucose, age, sex, and BMI. For the 8 acylcarnitines that were only quantified in greater than 20%, but less than 80% of samples, we recoded the levels as present or absent, and then we did logistic regression between the presence and absence of the AC and glucose change, and we did the same adjustments. We used a statistical significance at P0017 for Bonferroni correction for all the 29 levels. So these are the baseline characteristics of our population. As expected, we have a middle-aged, somewhat overweight population, pretty equal between males and females. I would just point out that their baseline glucoses on average were 91, and the glucose change on average was 2.2 milligram per deciliter increase. But what I would point out is the standard deviation, which is 9. So you can see there was huge variability in the amount of effect of the glucose, of the atenolol on glucose after a pretty short amount of exposure. This is just a list of the 29 acylcarnitines. Highlighted in blue are the ones that we only quantitated in the fewer patients, and the ones in orange are the ones that were well quantitated in most patients. So on to the results. The acylcarnitine C:24, or arachidonyl carnitine from the logistic regression, was our only strongly associated acylcarnitine, p-value of 6.9 times 10 to the minus 5 after adjustment for baseline glucose, followed by, does that mean my time is up? Okay, I'm hurrying. After further adjustment for age, sex, and BMI, the p-value was attenuated but still met the level of significance. These are our linear regression top signals, C18:2, C18, and C16, a cluster of long-chain acylcarnitines, were all trending towards significance, although after adjustment were not significant. So just to put these data into perspective, our C20:4, the arachidonic acid pathway, the data in the literature currently suggests that there is a very nice relationship with glucose, both in short-term exposure and long-term exposure. These are cell-based experiments, as well as arachidonic acid and palmitic acid interacting with glucose modulation. So we feel like the signals we're seeing from this pilot study make biologic sense. And in summary, I would just reiterate the long-chain acylcarnitines have long been associated with insulin resistance and diabetes. Presence of C20:4 was significantly associated with drug-induced glucose increase. Data from the literature demonstrate arachidonic acid is strongly associated with glucose regulation. And evidence from our GC-TOF data, which Oliver Fien's group helped us generate, show that palmitic acid and linoleic acid are also significantly associated with increased blood glucose after atenolol treatment. So in conclusion, data from our pilot study suggests that maybe someday the AC signature may be informative as a biomarker and might be leveraged for personalizing an approach to hypertension. Mechanisms associated with glucose change are probably similar for atenolol and other environmental exposures. And lastly, pharmacometabolomics is a recent focus for drug-induced diabetes, and I mentioned here some other classes of drugs that are also associated with diabetes and have been looked at with pharmacometabolomics. So I would just like to acknowledge the funding for this project and my co-investigators from PAIR, I list here, from Sanford Burnham, who helped us run these assays and analyze the data, and lastly from the Pharmacometabolomics Research Network, they're from Duke and Davis. So with that, I would be happy. I don't know if we have time for questions or.
We have time for at least one question.
Okay. A couple questions.
I'm sorry, how did the short-chain acylcarnitines behave in your study?
So we didn't really see any results with the short chains, but they were part of the 57 acylcarnitine package that Sanford Burnham had. So they were all run as part of the targeted assay that we had, and we were given the results. We didn't necessarily target them.
Oh, because you showed those results on the branched-chain amino acids and phenylalanine and tyrosine. So did you look at the acylcarnitines that correspond to those?
We
C3, C5.
We looked globally at the acylcarnitines. We did not, for our first pass, we wanted to take as much data as we could.